Dr. Krohn. Welcome to Deep Into Sleep podcast.
Thank you. It's a pleasure to be here.
I'm very excited that we're going to cover such an important topic today about sleep apnea. And my father was diagnosed with sleep apnea many years back. Once I started learning about sleep medicine, I learned about that. I immediately realized, something's not right about him. I noticed some symptoms. Not surprised. He was diagnosed and he was severe. So I want have this conversation with you today to help our audience to really understand more about sleep apnea.
Okay. I'll get started. So obstructive sleep apnea, and that's usually what we're talking about. There's central apnea, in which your brain doesn't tell you to breathe enough. That's far less common. And then there's obstructive sleep apnea, when you're actually breathing, but you have an upper airway collapse, which stops the flow of air. So it's not getting past your throat or getting past your neck. Air isn't getting into your lungs. And as a result, you're not getting oxygen properly into your blood, into the rest of your body. Your oxygen levels can drop quite low sometimes with obstructive sleep apnea. And then there's a few other things that are going on as this happens. You can have spikes in your blood pressure as your chest is working very, very hard to breathe in air and create a lot of pressure in your chest, which puts pressure on your heart, and you could have spikes in your blood pressure. All of these things can be damaging. And in addition to the obvious long-term damage of having low oxygen levels whenever you're sleeping or spikes in blood pressure that can persist even when you're awake, when these things happen, your brain wakes up a little bit. Sometimes patients are aware of it. Sometimes they're not aware of it. Sometimes they're aware of it and they attribute it to something else. Oh, I had to wake up and pee. But they are having arousals several times an hour, maybe dozens of times an hour, and they're having fragmented sleep. And that's going to affect mood. That's going to affect memory, thinking, cognition. That could put people at risk of dementia later in life. There's a lot of data on that coming out, particularly in women. And so it is more than just snoring, and it is more than just having fragmented sleep. Obstructive sleep apnea is essentially a systemic illness.
That's very good to know. When you lay it out like this, it's more clear. And it's so true. Like, for example, my dad, he snores, but he's not aware of it. And it's so loud, you can hear it from several walls away, but he insists, I did not snore. And so he's not aware of that. I know a lot of patients with sleep apnea come into the office because their partners, their family members refer them. They notice the symptoms and they are worried.
Well, Dr. Zhu, you bring up an excellent point. So the patient is either asleep or trying to sleep, is not fully conscious, and it's often the bed mate that is aware of the snoring, which, by the way, isn't present in everybody with obstructive sleep apnea. You can have obstructive sleep apnea and not snore, particularly women. But it's often the bedmate who is aware of the snoring and the house shaking from the snoring. And the patient himself or herself, although usually it's a man that's snoring, isn't aware. But the interesting thing is the bedmates of patients with obstructive sleep apnea are often suffering from the same symptoms that the patient with sleep apnea has. They're tired during the day because they're not sleeping either. They have headaches during the day because they're not sleeping either. They're in a bad mood. They're not having any interest in sex. The same things that are happening to the patient with sleep apnea are often happening to the bedmate also, because they're also suffering. They're like a secondary patient.
I like that angle. That's something I think most people are not really thinking about. And when one person has sleep apnea or have this kind of like sleep disorders, it may actually impact their partners, their relationships, even the whole family. And the partners may suffer from some symptoms and also insomnia if they it's so loud and their partners are light sleepers and they find this noise really annoying.
Right, right. I mean, you wouldn't expect somebody to fall asleep if the next door neighbor's dog was barking all night long,
Right.
or if they had a chainsaw going all night long. And so you can't reasonably expect somebody's spouse to fall asleep if the snoring is very loud. And so, yeah, it's
Mhm.
often a problem of two people.
Right, right. And you just mentioned sleep apnea may lead to a lot of health consequences or function consequences. And sounds like there are some factors may impact it too. I know if we drink before we sleep, our symptom of sleep apnea may increase during sleep, right?
Well, that's true. Alcohol is inhibitory. We all know that, if we have one drink, we drink moderately, we relax, our muscles chill out. But unfortunately, that also happens to the pharyngeal constrictors, the constrictor muscles in the back of our throat. And if they don't have good tone, they get floppy and they close off. Anybody who's ever lived in a college fraternity knows that on a Saturday night there's a lot of snoring, and these are not old men who are overweight. And so alcohol can really promote snoring. And if you have mild sleep apnea, it can make it much worse. And alcohol, as you know, Dr. Zhu, as a sleep therapist and a psychologist, not really great for sleep, period. Certainly not in the 3 or 4 hours before you go to bed.
Yeah. Is there any other factors people should be cautious about if they are worried about some symptoms of sleep apnea?
Well, I mean, in terms of risk factors for it, I mean there are a few risk factors that unfortunately we can't control. So, like one
Mhm.
risk factor is being a man. One one risk factor is being over 50. Hopefully, we all get there. One risk factor is being postmenopausal. We don't have complete control over that. And another risk factor is having a very thick neck, um, which we might have some control over regarding, diet and exercise, and but some of us are just built that way. Um, Risk factors that we do have some control over, drinking alcohol is certainly a big one. Um, our weight and our body mass index, although we know that we don't have complete control over that either. I mean, we may want to lose weight and go through tremendous efforts, but it's a very difficult thing to do. um, we know that sleep apnea not only puts somebody at risk for anxiety and depression, but anxiety and depression puts somebody at risk of obstructive sleep apnea. It's bidirectional. Um, we don't have total control of our moods. Thoughts are not completely voluntary. I've gone through cognitive behavior therapy myself, and so I'm aware of that. But if we're prone to anxiety and depression, things like cognitive behavior therapy may help us improve our sleep apnea.
Mm. Wow, that's all like very interesting data and to help us understand our mood, our physical health, our um, daily habit actually have close relationship with our sleep disorders, especially the symptoms of sleep apnea. And sounds like a lot of bidirectional relationship.
The more we talk today about obstructive sleep apnea, we're going to see that almost everything that we talk about is bidirectional. Sleep apnea will make a certain disease process worse. but that disease process, independent of sleep apnea, could put you at risk of sleep apnea. Um, you'll find that with anxiety and depression. Um, you'll find that with high blood pressure, not necessarily that high blood pressure causes obstructive sleep apnea, but having obstructive sleep apnea puts you at a very high risk of hypertension. And having
Mhm.
hypertension means that you might be somebody who has or is on their way to obstructive sleep apnea. There's a whole host of health conditions that are like that.
Wow. So it sounds like sleep apnea really impact our physical health, mental health in so many different ways. When I treat insomnia clinically, sometimes I also educate patients that don't worry about insomnia that much. Think about health consequences. There are many other sleep disorders can do much more harm to your body, to your mood. And sleep apnea is one of those. Sleep deprivation is another one. So then sounds like it's very important for us to be able to catch this as early as possible to understand, oh, maybe this is a symptom, this is a condition I really need to look into to either treat it, deal with it, manage it. So what are typical ways for us to figure out or have a diagnosis of sleep apnea?
Right. So traditionally, the manner in which the diagnosis has been made is with an overnight sleep study, where you either go to a laboratory or increasingly you go to your home. You have certain sensors that are hooked up to various parts of your body. With home sleep tests, it's less, there are less sensors. And then various things such as your chest movement, your limb movement, your eye movement, perhaps an EKG, perhaps an EEG of your brain, a pulse oximeter that's measuring your oxygen saturation. Far less of these in a home sleep test, obviously. These are collected, and then based on certain results, it's determined whether or not you have obstructive sleep apnea. At Conk, or conksleep.com, we use adaptive logic questionnaires. We forego the overnight sleep study. We don't put people through that because we know that with the informatic power of asking the correct series of questions, you can get a diagnostic accuracy that is similar or essentially the same um, as polysomnography, which is the laboratory test, or a home sleep apnea test. This, of course, is in patients who don't have other very significant illnesses. We would not use adaptive logic questionnaires, for example, in somebody who has narcolepsy or epilepsy or congestive heart failure. We would not use these to make the diagnosis in people who use opioids or benzodiazepines. I want to be very clear that what our adaptive logic questionnaire, what we call our digital clinical interview, we are going uh, to identify people who have the most obvious signs and symptoms of obstructive sleep apnea and don't have serious medical comorbidities that would make in-person evaluation by a sleep medicine specialist more appropriate.
Yeah. So when we talk about traditional method, myself and my family member went through the traditional method. Either you do a in-lab sleep study
Right.
overnight, like what you mentioned, or at home sleep
Mm-hmm.
study, less accurate, but still can give some good information. They mail a little device to home. So I'm wondering, I know you build a company, sounds very cool that you provide a new way of really diagnose this and fast and get treatment to patient much faster. I want to understand what motivates you to do that, to build such a platform. What kind of problem you have noticed in the traditional way of diagnose and treating this disorder?
Right. Well, I myself have obstructive sleep apnea. I happen to be a physician, but I'm a patient, and I had to go through the journey. of getting diagnosed and treated, and I had to experience all the pain points. I had to go to my primary care doctor and have an in person appointment and tell my primary about the problem that I was having. I then had to get referred to a sleep specialist. I had to wait for the first available appointment. I had to go in, pay another copay, um, and tell that sleep medicine doctor the same thing I told my primary. Then I was referred for an overnight sleep study in a laboratory. I had to get approval and prior authorization from my insurance company. I had to wait about 2 months between getting the approval and then getting on the schedule at a sleep lab. I then had to go in the sleep lab and go into the lab and try to sleep with all those wires on. And guess what? I slept enough to get the diagnosis of obstructive sleep apnea, which I already knew I had, but not enough for them to see if my machine was working properly at the right pressures. So they told me that I had to come back for another study to have what's called the titration study, which I refused because there are automated positive airway pressure machines, and you don't have to have a titration study. There are machines out there, as a matter of fact, the majority of the market that detects your airway resistance and then gives you the pressure you need. So you don't need anybody to set it for you. I then learned that the overnight sleep study cost $7,000, and my co-insurance put me on the hook for 10% of it. So I had to pay $700 plus the two copays before to have a study that was only partially helpful, to be told that I knew what I already had, and now 3 or 4 months had gone by. Then I had to wait for the sleep study. I had to wait for the sleep study to be read by the sleep medicine doctor. Then I had to go back in, pay another copay, and review my results. And then I had to wait again to get approval and prior authorization of my positive airway pressure device. Then I learned that my insurance company doesn't pay for the positive airway pressure device. You have to rent it for a year. You don't actually own it. And they monitor your usage. And if you use it enough, then you get to keep the device. If you don't use it enough, they take it back from you, but you don't get your money back. And they don't charge you over the course of that year the wholesale cost of the machine. They don't take the wholesale cost and divide it by 12 and charge you that per month. They take the retail cost and divide it by 12. So the disease management company, or the DME, the durable medical equipment company, they're making retail profit on you, and you're responsible for it, even if you have private insurance. Then, so the machine arrives, and then nobody teaches you how to use it. I had a representative from the DME distributor come to my house, show me how to clean it, and left after 10 minutes. And you would never drop an insulin pump off at somebody's house and expect them to teach themselves how to use it. So I failed miserably in my first few nights on the machine. I couldn't tolerate it. I didn't know how to use it. And so I did it's a good thing I'm a doctor, because I could understand what I needed to do. But I had to DIY it. I had to go onto YouTube and teach myself how to use the device. And then I got no support. I just happened to do well. And then what Conk has come up with is a solution to that journey, a solution to the onboarding, and also cost certainty. The average American who has private insurance and has obstructive sleep apnea spends $2,100 a year out of pocket on copay, co-insurance, and deductible. And I said to myself, I think it's cheaper to do this without insurance. I think I can come up with a cheaper, more effective, and frankly safer way to diagnose and treat patients with obstructive sleep apnea.
Wow, wonderful. Yeah, I totally understand the pain of your journey. I went through part of that, and the sleep study was so expensive, and it's like I did not meet my deductible. I have to pay more than $1,000 just for at home sleep study,
Well, you were
and
lucky. You were lucky. I mean, you paid over $1,000, and you were one of the lucky ones. Some people have to pay even more.
yeah, I know, but still, that's a huge bill. When I got it, I was like, "What for this little thing?" And that's it. Fortunately, I was not diagnosed, but still, I cannot imagine what other troubles I have to go through because I witnessed how my father goes through all this journey. But he did it in China. That's another story when the resource is very limited in a country,
Yes.
right? Yes, he was diagnosed, and that's all fine. That's easy. No long line, no long wait. You just pay money, and then they get you tested. But then you get the machine. I bought the machine in America for him, but then what? How to use it and what is involved in it? No idea. Nobody teach him. It just he cannot tolerate it. So there's a lot of like problems afterwards. And also, since he has diagnosed in another country, if he move here, what should we do about that? I don't know,
I
right? So it's a lot of difficult things we have to navigate, and it's very complicated. So I'm very excited that to see your platform. Seems like you really streamline everything, make it fast, make it cheaper. Can you
yes.
explain more what you guys do exactly?
Right. So the intake, what we call the digital clinical interview, and takes about 10 minutes to fill out, which is an adaptive logic questionnaire. That takes about 10 minutes to fill out. And we can make a positive diagnosis with about 90% or more accuracy by asking the
Mm.
right questions. It takes about 10 minutes to fill out. If the questionnaire indicates that you probably have sleep apnea, we have a physician who's licensed in the state in which you live
Mm.
review your medical record, um, confirm the diagnosis, and then issue a prescription. And that usually happens within 1 to 2 business days. So within 1 to 2 business days, we can get you your diagnosis, and that costs $39. That
Wow.
cost
Okay.
that costs $39. As a matter of fact, we had one customer who took the questionnaire, who took the digital clinical interview during the Super Bowl a few weeks ago, and received the formal diagnosis at 10 o'clock the next morning with a chart note reviewed by a physician in his state and a prescription issued. Then, once you have the diagnosis, we ask the patient, do you want to proceed with therapy, get your machine, and get the 90 days of support? And if the answer to that is yes, the whole bundle, including the $39 you've already paid, is $11.99, um, just under $1,200, which is far less than the $2,100 on average that people are spending. And then you get an automated positive airway pressure device that is shipped directly to your home. And then within 3 days of the device arriving, we get you a one on one video teleconference with a respiratory therapist for 45 minutes to teach you how to use your machine. And then you get 90 days of patient support. So 90 nights of AI monitoring of your device usage. So we know who's still having difficulty with their breathing during sleep and who's not. Those who are having difficulty, we have a respiratory therapist or a sleep coach contact them immediately. And this goes on for 90 days. And that's all one bundled financial package. There are other companies, nobody's doing it with adaptive logic questionnaires. They're doing it with home sleep studies. But everything is like an item on a menu. There's an a la carte payment. If you want the support afterwards, it costs more. Everything is one clinical interface, one bundled financial package, complete cost certainty.
Mm. So my question is, sounds like you really use this clinical interview. and this doctor reviewed chart to replace the long journey of sleep study. Am I
Yes.
understanding you correctly? So it
Abs-
means your platform, patients don't have to go through any kind of sleep study.
Well, they go through a clinical interview, but no, in terms of being hooked up to wires and pulse oximeters and EKGs and having to go overnight, no, they don't. Now, we do work into our algorithm. We do ask questions. So right now, the Samsung Galaxy Watch is FDA approved for the
Mm.
diagnosis of obstructive sleep apnea, not just FDA approved for
Oh,
sleep tracking.
oh.
Um, it is FDA approved to make the diagnosis. Most sleep medicine specialists will only treat that as a screen and then put you through another sleep study. We accept that data. We don't act on it alone. We then adjust the algorithm and we adjust the way we interpret your responses to questions and weight them differently if you've already been diagnosed. Same with the Apple Watch 10. The Apple Watch 10 is FDA approved to make the diagnosis of obstructive
Oh.
sleep apnea. Uh,
Mm.
Most or almost every sleep medicine specialist is treating that as a screen. Um,
Mm.
we treat that as a powerful data input. We don't use that data alone. We won't give somebody the diagnosis just because they tested positive from Apple or the Galaxy. But we weight that in how we interpret the rest of the responses in the digital clinical interview. And we also, 30% of patients who've been diagnosed with a sleep study never do anything about it. So that, there's
Right.
between 1 and 2 million Americans who it's not just that they think they have it, they know they have obstructive sleep apnea, and they never went through with getting any kind of therapy for it. We will accept the results of an old sleep study. We don't make people reinvent the wheel. And keep in mind,
Mm.
self referral to a sleep lab or to a sleep doctor or to a doctor who treats sleep, self referral is in itself a risk factor. People who go to a sleep medicine specialist, between 80 and 95% of them have obstructive sleep apnea. So, you so what's called your pretest probability, the chance that the patient has it just by showing up on our
Mhm.
platform is extremely high. And then
Mm.
if they have other risk factors, then it's super, super high. So they refer themselves to us, and they're a man, or they're
Mm.
over 50, or they're sleepy during the day, or they're in menopause. Well, then, or they have obesity. The numbers just, the incidence rate skyrockets. And to put people who are otherwise healthy, and by that I mean not having congestive heart failure, don't have neurodegenerative disease or opioid addiction or things like that, to put them through the whole process, especially if they have objective data from FDA approved devices, um, it's not necessary. And it's a strain on the system, and it's very much a strain on the patients.
Mm. Okay. Yeah, you mentioned earlier, some, especially women, if they have sleep apnea, but they may not snore,
Yeah.
right? So everyone, their symptom may look different. So I'm wondering, for a patient come to your platform, but they may not have any of the device you mentioned,
Yes.
they don't have those kind of tracking data or screening data available. Can your doctors, just by reviewing their symptoms, their self-reported symptoms and concerns, to make the diagnose, or you need something else?
No, we can, if they don't have the objective data
Uh-huh.
from a device or from a prior study, no, their responses, um, their their body habitus, their gender, their report of symptoms, and what those symptoms are. Are they having morning headache? Are they having daily headache? Are they sleepy? Are they fatigued? Are they snoring so loud that they keep their bed partner up? Are they having
Mm.
gasping or choking? The presence of comorbidities, menopause, blood hypertension, high blood pressure, type 2 diabetes, um, the absence of certain um, medical conditions, which because that if the patient did have would suggest that something else other than sleep apnea was going on. There's a whole host of things that you can ask about. Their waist circumference, their neck circumference. You can get a very complete picture on somebody's risk for obstructive sleep apnea, and then the presence or absence of sleepiness and other symptoms. And you can make the diagnosis again when between 80 to 95% of self referred people have it. You already are having accuracy that's approaching that of an overnight sleep study. And by the way, overnight sleep studies miss about 25% of patients. A
Mm.
lot of people go to the sleep lab, they can't sleep, and you don't have enough
Yeah.
data to make the diagnosis. With the home sleep tests, the device may fall off, and you don't have a sleep technician in your home to come in while you're sleeping and put it back on. People have good nights. Part of the reason I really am accepting of the Apple and the Samsung Galaxy data is that the Samsung Galaxy data, you have to have at least 2 nights of data in a 10-night period.
Mm.
And in the Apple data, they make the diagnosis over the course of 30 nights.
Oh,
I mean, so their data may be imperfect, but they're collecting so much more of it.
right, right.
And so that makes those devices very useful. But now you have the information, and it's hard to find a
Mm-hmm.
doctor who knows what to do with it.
Mm-hmm. Yeah, yeah. And it's amazing you can make the price so low for the bundle because I know the machine itself is already expensive. And then meeting with a doctor or specialist to talk each time normally cost a lot of money.
We are interested in delivering high quality healthcare at value. Um, I'm a physician and a patient. I know from both sides how important that is. Um, and you want to make people feel better, but you don't want people to resent the journey, the process, or the cost.
Right. Yeah. And I think it makes sense because in the sleep study field, I did hear from different doctors talking about the concerns or the hope that we can get more nights of data, not just one night, because most sleep study, right, even at home sleep study, many of them can only measure one night. But I noticed there are more devices nowadays are trying to measure multiple nights of data.
Right, the consumer wearable. So most of them are FDA approved for sleep tracking, meaning they'll just
Mhm.
give you data about your sleep, what percentage is deep sleep, what percentage is REM sleep, what percentage of your time in bed is spent asleep and spent awake. And they can give you data that is important and in some ways actionable, but it's not diagnostic. Um,
Mm.
in terms of the over the counter devices that are FDA approved for diagnosing obstructive sleep apnea, to my knowledge, it's only Apple and Samsung right now.
Mm-hmm. Yeah. And for your platform, I'm wondering because over the years, we keep on hearing that, oh, sleep study is the golden standard for the diagnosis uh, of sleep apnea. Now you are creating this different procedure of, we don't have to solely rely on the sleep study. I'm just wondering, have you like how other sleep doctors react to it? Have you like received any um like difficulties in the process of trying to see, hey, there's a new way of doing this?
No. As a matter of fact, I've had a prominent sleep medicine specialist reach out to me to tell
Oh,
when he heard about what Conk is doing. And this will be an announcement that comes out in the next couple of weeks, but he's going to be on our medical advisory board. Um,
oh,
I am sure there are sleep medicine doctors who aren't thrilled by this, and I am sure that there are going to be some who take issue. Um, but again, we are screening out patients who have serious health conditions, who are on serious medications. We're screening out airline pilots, train operators, um, uh, uh, military pilots, astronauts, where anybody who is responsible for transit and mass transit, we are being very, very careful. Um, and we are, look, in the Sleep Academy's efforts to be completely 100% accurate, which they're not anyway, but in their effort to have 100% accuracy, you have 80% of the country undiagnosed. 80% of the patients who have obstructive sleep apnea. There are at least 30 million Americans who have obstructive sleep apnea. Only 6 million have been diagnosed, and 1 or 2 million of them aren't even using a device. So what the current sleep guidelines have done is essentially said we want complete accuracy in diagnosis, even if it means that 80% of the patients with the disease are completely undiagnosed and untreated. And it's not that this is their intention, but the result is that you have 24 million people who are walking around with an increased risk of heart attack, of stroke, of atrial fibrillation, of car accidents. For every 1,000 untreated patient years of obstructive sleep apnea, there are 2 to 4 excess mortalities. That came out of the Wisconsin sleep study about 15 years ago. I mean, we've known this data for 15 years. That means there's about 40 or 50,000 Americans dying preventable deaths every year because of obstructive sleep apnea. And I understand, I'm a doctor, I understand what it's like to want to know with 100% objectivity. But the cost of that is that we have a silent epidemic. And I haven't even spoken about the non fatal diseases that can have significant impact on negative impacts on people's lives: erectile dysfunction, sexual dysfunction. I mean, these are distressing things um, that are pretty common in men over 50, and it um, it affects their quality of life, and it can be treated. And by the way, the best treatment for erectile dysfunction in somebody with obstructive sleep apnea are the phosphodiesterase inhibitors, Viagra, Cialis, things like that, plus positive airway pressure. The two together work better than either one alone.
Yeah, yeah, for sure. And yes, talk about sleep and sexual dysfunction. There's a close link between that for sure, and between sleep disorders and sexual desire, also not only among men and also among women. Yeah, so since you are talking about this, I do want to ask, what are the common treatment for obstructive sleep apnea? And it's just CPAP machine, anything else?
Yeah,
And are those included in your platform?
right. So the most common and the most effective is a positive airway pressure device, either an automated, an APAP machine, which people
Mhm.
commonly just call a CPAP machine because they're more familiar with that term, or a CPAP, which is continuous positive airway pressure, in which the pressure doesn't change. If
Mm,
you can use an APAP, which not everybody can, but if you can use an APAP, that's better because it's going to deliver the minimal pressure that you need and change overnight. If you roll over and your pressure requirements change, if you change your position in any way, if as you enter deeper stages of sleep, your airway resistance changes, the automated positive airway pressure machine is making adjustments. CPAP is good too, but it requires closer monitoring by a doctor because your pressures might need to be adjusted, and only your doctor can get into the machine and reprogram it. Other modes of treatment are also available. Currently, Conk does not provide them. Right now, we're concentrating on offering the most effective treatment that's likely to improve the most people. But there's oral appliance therapy, mandibular advancement devices. Those generally don't work as well as positive airway pressure devices, but for some people, they're sufficient. And I will not deny that for a significant minority, that could be helpful. And now there's hypolingual nerve stimulators, in which you actually have a electric pacemaker put in your chest with a wire that runs up to the base of your tongue. And then when you breathe, your tongue is stimulated to jut forward, and you have a more open airway. That's only available for a small minority of people. You have to have a pharynx, a throat that's of a specific shape. You have to have, it has to have a anterior-posterior diameter, not a circular shaped diameter. You have to have failed CPAP or APAP to be eligible for it. You have to undergo sleep endoscopy. You have to be put under anesthesia that allows you to sleep, and they have to put a tube into your pharynx and your upper airway to see how you're breathing. Very invasive. And that's an extremely long journey. That wouldn't be anybody's first stop anyway. And then a great adjunct to sleep apnea therapy, to any of these devices, but positive airway pressure is what I'm going to focus on, is CBTI, cognitive behavior therapy for insomnia. Well, a lot of your insomniac patients, Dr. Zhu, I'm sure have sleep apnea or sleep apnea and other things. People who have well-treated obstructive sleep apnea with a positive airway pressure device may still have difficulty sleeping because they also have anxiety. Or, they also have other things going on in their lives that need attention, or just difficulty relaxing at the end of a stressful day. We currently do not offer CBTI, but that's a discussion that we have.
Okay, great. Yeah, so it sounds like there's a lot of options. And your platform, if I understand correctly, provides this APAP, right?
We distribute only automated positive airway pressure devices. And by the way, our respiratory therapists in that 90-day period do have access to make adjustments, and those adjustments are directed by our physician, who has signed off on pressure parameters and setting parameters.
Great. And sounds like if for a situation like my father's situation, someone got diagnosed in another country or previously, they can bring all their chart in and get all this reviewed by a doctor in your team, and then they possibly can get automatic PAP machine from your platform and start the treatment.
So we would include, prior objective data that is clinically rigorous, like an overnight sleep study. We would include that in our algorithm. We wouldn't use that information alone, but we would give it significant weight. I have to tell you something. You speak about your father bringing his study from China. I'm a pediatrician, and for almost 30 years, it has driven me crazy when we have immigrant patients who come in with their vaccination records, and
Oh,
everything is, and we don't accept them because they were given in another country, as if the physicians or the health ministry of a foreign country is going to create this objective data that didn't actually exist. Like they're going to spend all of that time. As I've practiced more and more, I have learned that although sometimes you get burned, 99.9% of the time you're better off believing your patients.
I like that. That's so interesting. Yeah. And another thing, I'm sure a lot of audience, when they hear now, they want to understand the payment.
Yeah,
Do you accept insurance? What that may look like?
right. So ours is self-pay, but there are important factors that we should review regarding that. Number one, we accept HSA, FSA, healthcare savings accounts, flexible savings accounts. So if people have funded their HSA or FSA account, we accept that 100%. It's already paid for. Number two, we do use the Stripe and Klarna credit card processing platform. So we do have installment plans. People can pay quarterly, people can pay monthly for 6 months, 12 months, 24 months, paid out monthly over the course of a year. It's about the cost of a gym membership. So those can be spread out if you don't have HSA and FSA. And we do provide receipts. And so receipts can be submitted. You never know how that's going to go with someone's insurance company. But for people who can submit to their insurance company, we do provide that.
Okay. Kind of like a super bill.
Yeah.
Mm-hmm. Okay.
And we
Good to
itemize.
know.
We itemize
Mhm.
everything.
Yeah.
We itemize the cost of everything, so that
Right.
if you had to submit it to your insurance company, it could be seen. Insurance
Mm-hmm.
companies are not amazing at working with those reimbursements for self-submission, but if you have a plan that accepts that, we can accommodate that.
Right. Mm-hmm. So I think it's very clear that if people want to self-pay or with their, FSA, HSA, they can just use that to pay. And the price you guys offer are reasonable considering how expensive the machine already is and a regular sleep study is. And especially for people who are generally healthy, they may have a high deductible plan. And the first several $1,000s for most people, if they're healthy, maybe they're gonna have to pay out of pocket anyway. So
Yeah,
I think it's
or wait till the end of the year. So here you are
yeah.
sick in January and you're waiting until December for you to fill the deductible. Meanwhile, you're, at risk of um, falling asleep while you're driving, which is what happened to me 3 days before my device arrived. I was driving
Mhm.
on I-80 in Pennsylvania, going to visit my son at college. I had my three other sons in the car with me, and I fell asleep.
Oh no, that's dangerous. That's very dangerous. That's one most dangerous thing we want to caution patients with sleep apnea is this falling asleep behind the wheel, this excessive daytime sleepiness.
Untreated sleep apnea patients have uh, excess mortality from car accidents,
Mm, right.
unfortunately,
Wow.
but not
Yeah.
surprisingly.
Yeah. Glad you were able to be treated, and now you are providing this resource to a lot more people out there so they can get diagnosed and treatment much faster at hopefully a lower cost than their typical procedure. I'm sure this can benefit a lot of people.
Yeah, yeah. We're conksleep.com. We're here.
I will put your platform, your company's information down in our show note. So whoever are listening, if they're interested, they can just go to the description section and find the information and check out more on your website. Anything at the end of our conversation? Any last wisdom? Anything else you really want to share with all of people who are listening right now?
Yeah, I think that there is a tendency, particularly as we grow older and we grow into health conditions that are common, to think that because they're common, they're normal. High blood pressure is common in people over 50. Um, being tired, snoring so loud that your spouse can't sleep. These are common, but we shouldn't accept them as normal. It's not normal to need to drink 2 pots of coffee a day, as I used to do. It's not normal to be somebody who always valued their sexual life and loves their spouse, but not be in the mood to engage in a relationship that way. These things are common, but just because they're common and 6 to 12 other people who have the exact same thing as you doesn't mean it's normal, and it certainly doesn't mean it can't be addressed. And positive airway pressure devices are very safe. It's not a medicine that goes in your body. The major side effect is a dry nose or a little bit of a rash underneath your nose. Oh, that's another thing. We start everybody on a nasal interface so that their face is wide open, and we only use under the top tubing. So the tube it's not an elephant's nose that goes in the front of your face. Our tubing only
Oh,
attaches up on the top of the head on a swivel. So your face is wide open. You can hold your bedmate. Your bedmate can hold you. You can roll over. The machine won't move because the attachment is on a swivel on the top of your head.
oh, perfect. I think that's a pain of my own family. And yeah, I'm possibly gonna have to check out your company and get a machine from you guys later, if my father can be diagnosed again.
Yeah.
Yeah, that sounds great. Yeah, I the old style machine was like it's underneath the mouth or nose area. It's so hard to think about how someone can turn and be comfortable at night, which of course he's not comfortable, so he does not want to use the machine. And as family members, we feel worried,
Yeah.
right?
No.
Also, with someone with the knowledge of sleep medicine, I'm even more worried. But there's no way I can force my parents to use the device to really help themselves. So it's such a struggle for me for years.
And then you need support for 90 days.
Mm.
And or you need support for as long as you need the support. um,
Right. And the support piece is really cool. Sounds like the support is just a specialist can answer questions, can troubleshoot,
yeah,
basically.
it's a respiratory therapist, and I mean, in my opinion, traditionally the diagnosis has been made by sleep medicine doctors, and the prescription is issued by sleep medicine doctors, but the treatment comes from the respiratory therapists. It's like when you're in a hospital, the doctors write all the orders, but the nurses do all the work. It's the same thing in the obstructive sleep apnea ecosystem. I mean, not 100% of the time, but the doctors write the orders, and the respiratory therapists or the sleep coaches do all the work.
Yeah. Yeah. I think this is very valuable information you provide, and I think it's also very important, as you mentioned, do not take these symptoms as normal. Which
Yeah.
I hear that from a lot of people. Snoring is normal. It's like feel sleepy during the day is normal. No, they're not normal, and pay attention to the signals your body give you, right? And
and don't
try to,
assume it's the most likely
yeah,
thing. So like another thing, it's very common. Oh, every guy wakes up 2 or 3 times a night to pee in the middle of the night. It must be my prostate. But sleep apnea causes you to urinate several times a night. In the body's effort to reduce blood pressure, you produce more urine. There are tons of urologists' office with men who think they have enlarged prostates or stay at home and never even go to the urologist. They assume it's their prostate and it's their sleep apnea. There are many women who are having significant fatigue and sweating at night, and they just assume it's menopause. It's a reasonable conclusion, but obstructive sleep apnea also makes you sweat at night and also makes you tired all day long. And so there are things that are true. I have menopause, I have an enlarged prostate, but they have nothing to do with the fact that you're feeling the way you do, and it can be treated in a completely different manner.
yes. Oh, that's so important that I'm happy we landed there.
Yeah,
So everyone, whoever listening, watching, can really pay attention to this. Don't make assumptions. And sleep apnea could make some of the symptom even worse.
absolutely. And it's rarely only one thing that people. I
Mm.
mean, you know that as a psychologist,
Yes,
it's usually more
totally.
than one thing.
Right. It's all like a holistic view. We need to treat a person as a whole person. It's just not one thing.
Yeah.
But hopefully we all start pay more attention to that. Listen to the signal our body gives us. Don't make assumptions. Seek out professional advice, seek out professional diagnose, and to really understand what's going on and target the problem.
Agreed. No argument
Yeah.
here.
Thank you so much, Dr. Krohn. This is very, very helpful information. I hope our listeners got a lot from our conversation today.
Thank you, Dr. Zhu. It's a pleasure, and I look forward to coming back sometime.